When we evaluate patient for suspecting demyelinating disease, our eyes naturally drift towards the brain scans. But the spinal cord is often the true diagnostic heavy lifter in neuro-immunology. If you look at the sagittal T2 weighted image shown here, you can see exactly why this sequence is so critical. In McDonald criteria, finding a single lesion within the spinal cord carries significantly more diagnostic weight for demonstrating dissemination in space than finding multiple lesions scattered across the cerebral hemispheres. It's a highly specific region, meaning that if you spot an inflammatory lesion here, your clinical suspicion for primary demyelinating process should skyrocket. Looking closely at the cervical cord, you will notice multiple discrete patchy area of T2 hyperintensity. When you are analyzing these scans or teaching somebody, the absolute key to differentiate multiple sclerosis from its mimic is the lesion length. Notice how these specific lesions are focal and short, spanning less than 2 contiguous vertebral segments. If you ever encounter a lesion that stretches across 3 or more vertebral levels, what we define as longitudinally extensive transverse myelitis, your differential must immediately pivot away from classical MS and straight towards the neuromyelitis optica spectrum disorder and MOG-antibody-associated disease. There are intense anatomical stakes involved when dealing with the spinal cord compared to the brain. In cerebral hemisphere, you have vast expanses of white matter and a high degree of functional redundancy. In the spinal cord, however, has absolutely zero real estate to spare. Every single millimeter is tightly packed and ascending sensory pathway and descending motor tracts. Because of this extreme density, even a tiny innocent looking T2 hyperintensity like the subtle one visualized here in this image can completely disrupt signal conduction. This explains the classical clinical radiological mismatch where a patient presents with profound neurological deficit like a distinct sensory level or a spastic paraparesis, despite a scan that only shows a few millimeter sized spots. While a sagittal view like the one shown here is excellent for identifying the presence and the craniocaudal length of the lesion, you must always correlate these findings with axial cuts to see their exact cross-sectional position. Classical MS lesions are notoriously eccentric and peripheral, preferentially striking the dorsal and the lateral columns. This structural preference explains why the patients so frequently present with symptoms like hermit sign or posterior column signs, such as a loss of proprioception or vibration. If your axial cuts instead show symmetrical central gray matter involvement, that is a massive red flag that should prompt you to look for ischemic, metabolic, and alternative inflammatory etiologies. Ultimately, a dedicated spinal cord MRI should never be treated as an afterthought or a secondary scan. When you are faced with a tricky or ambiguous clinical picture, such as a clinically isolated syndrome where the brain MRI is borderline or unrevealing, imaging the cord is often your fastest route to diagnostic certainty. Recognizing these characteristic short segment peripheral T2 hyperintensities allows you to secure an accurate diagnosis early and bypass the common diagnostic mimics, and confidently initiate disease modifying therapy before permanent axonal transection and irreversible disability sets in.